So good morning, everybody. Just like we offered for our last grand rounds for attending this live session, you can claim the CME credit texting the number and the code. I'll put it again up in the chat as we get started here. Moving forward, this will be offered as enduring material, but the Baylor site hasn't been set up for that just yet. But we will communicate to you when that is offered, so you can tell your colleagues who weren't able to join today. It should be set up in the next few weeks. And so that's that, I think. Dr. Rienswijk, do you want to?
Okay, good morning, everyone. Thank you again for joining us. And we are going to have an interesting morning talking about flu season in the context of the hopefully winding down, but not quite winding down, COVID-19 pandemic. We have some excellent speakers and colleagues who have agreed to join us this morning, and I'd like to start by introducing those folks. First, Dr. David Quimby is an assistant professor of medicine and infectious diseases at Creighton University, in addition to being the medical director of infection prevention for CHI Health in the Midwest Division. He's a graduate of the University of Miami Miller School of Medicine and did his residency and infectious disease fellowship at the University of Illinois in Chicago. So welcome, Dr. Quimby. Next, we have Karen Dykes, who is an infectious disease advanced registered nurse practitioner who's been practicing both inpatient and outpatient in the Pacific Northwest for 14 years, where she serves as the director of infection prevention. I was privileged to meet Karen during the start of the COVID pandemic, when she served on the Ambulatory COVID-19 task force, including being a member of the monoclonal antibody subcommittee, where she wrote some of those protocols that we used across the country. And what's notable about Karen is that she collected the swab on the first COVID-19 positive patient in all of Common Spirit Health. So did you save the swab? Is it like on your wall or anything?
No,
it's long gone. Yeah. All right. And last but not least, Dr. Lilia Pararodi, the academic chair for pediatrics for Dignity Health Medical Group in Phoenix. She is chair and professor of pediatrics for Creighton University School of Medicine for the Phoenix Regional Campus. She's a member of the Common Spirit Health's Physician Enterprise Ambulatory Collaborative Work Group. Dr. Pararodi earned her medical degree from Stanford University School of Medicine and completed her internship and residency at St. Joseph Hospital and Medical Center in Phoenix, Arizona. She's a native of California, and she earned a certificate in healthcare research and design and teaching from the Arizona State University in 2005. And so with that, again, welcome. And of course, we have Dr. Sagar here, Dr. Ankita Sagar, John Knishi, and Brooke Burgess, all part of our panel this morning. So with that, I think we're going to start with Dr. Quimby.
Thank you. And I will just do what are the viral testings that we do? Okay. As I mentioned, I have no conflicts of interest. Okay. So when you're talking about diagnosing a virus in somebody, there's really three ways to do it. You can go old school with a culture, there's antigen testing, and there's PCR testing. Okay, you don't often see cultures a lot anymore, and there's a couple reasons for that. It's slow, it takes a long time. So if you diagnose somebody like 2 weeks after the fact, any sort of window you had was closed. Sometimes you'll still see this on like a bronchoscopy specimen or something like that, but it's not generally used that much anymore. Antigen testing is very fast. You get your result generally within 10 or 15 minutes. Compared to PCRs, it's relatively inexpensive. And the problem with antigen testing is you have varying sensitivity specificity, which relates to your predictive value of the test, depending on the test itself and population, what's going on out there. If you really want to know, you can do a PCR or nucleic acid amplification, but the problems with this is it's the most expensive of the tests, And how long it takes to get your results depends on where you are. If you're right next to the reference lab, you'll get your result quickly. If you're not near a reference lab and they pick up stuff at the end of the day, and then there's a day for delivery, and you can have days before you get a result. The other problem is, because it is very sensitive, and we've seen this with COVID along the way, your PCR can be positive for a lot longer than you care about after somebody's well and truly healed. PCR as how good it is. So looking at antigen testing, RSV, not generally done in adults. Why? Because according to these people who researched it, it had a less than 30% sensitivity rate. On top of that, RSV tends to not be an issue in adults as much as in children, like my pediatric colleague will mention, but sometimes you'll see a case in an adult and you only pick it up and they're not that sick, or they have end-stage lung disease. Flu virus testing, you do have in adults. If you're comparing to a PCR for influenza, according to CDC data, your sensitivity is as listed, your specificity is as listed. Those are intrinsic to the test, but don't necessarily help you diagnose a patient. Because if you're looking at positive predictive value or negative predictive value, it really depends on what's going on in the community. For example, if you have no influenza in the community whatsoever, and you have a positive influenza antigen, it might actually have a higher chance of being a false positive than a true positive. And if your community is absolutely riddled with flu, like we've had some years before, your negative antigen test might have a better chance of being a false negative than a true negative. On average, it's not quite as good for flu B as flu A, but you take what you can get because it's fast. When you look at COVID antigen testing, we generally don't do that in most of our areas, but pretty much everybody and their brother have home tests. You can get them from the federal government for free. Some clinics that are not ours do them. I don't know if there's still drive-up areas or not, but they're all over the place. There's a variety of studies looking at sensitivity of it, and it really varies depending on the study being performed and when it was done. It varies from 60% to over 80%. So it's okay. All right. So if given the community level of COVID, if you have a positive test in the face of appropriate symptoms, it's fairly diagnostic. A negative, however, does not exclude disease. I can, just to pull an example out of thin air, say there's a 46-year-old infectious disease doc and his 20-year-old daughter who both get symptoms on the same day, and they both test negative and positive 2 days later, okay? Just random example, okay? So if you're trying to exclude COVID, you need to have serial tests that are negative with an antigen. So there's tests out there. Why are you testing? And there will be an algorithm that's shown later about when it's appropriate to test. But why you would test is things have changed a little bit since December 2019. Before then, if somebody came in the height of flu in December, January, February with flu-like symptoms, you would probably get an influenza swab in clinic, but you might end up, if they had appropriate risk factors, giving them Tamiflu anyway, depending on community activity, regardless of the swab result, knowing that your negative predictive value might not be that great, okay? We're not there anymore. We now have two different things that can have widespread activity. So if you're giving oseltamivir to somebody with COVID-19, it's probably not going to help them very much, okay? Once you have more than one thing that's treatable, it's a lot tougher. One other thing to test is if you can diagnose somebody with, say, influenza or COVID, you can limit their, hopefully, antibacterial exposure. Giving everybody a Z-Pak or amoxiclavulinate does not help their viral infection, and there can be collateral damage to those or side effects. If you're looking for PCRs, because we just talked about antigens, generally for respiratory viruses, there's 3 of them. You can do a straight up COVID. This lets you know if you have COVID. Doesn't look for anything else, just COVID. On site, you can combine it with influenza antigen, and your turnaround time really depends on where you are. What's used in a lot of areas is a respiratory fourplex, which looks for 4 common circulating viruses: RSV, flu A and B, and COVID. RSV, honestly, in the adult population, which I deal with, is less relevant, but there are the little short ones out there. So there you go. It's generally more readily available than the expanded panel. And if you have it on site, it's got a fairly rapid turnaround time. It does find in the adult population the 2 most common things that you can treat, so it's useful. The big panel looks for a lot of things. The one that we use here in the Omaha Metro has 23 targets. That's not necessarily 23 different viruses, because there's 3 subvariants of parainfluenza in there, that kind of thing. It will also look for some bacterial pathogens too. So those are the PCRs that are available. The question is, which of those would you pick? Would you do any of them at all? So if you're working in a clinic, often there's not a lot of point to the expanded panel. You're not going to get your results right then. So you're making a therapy decision anyway before you have any results. And most of the things you find on that, you can't treat. Okay. And it would be great to have a discussion with the patient. Okay, we did this very large, expensive PCR. You have human metapneumovirus, have some chicken soup, and have fun paying for that $2,000 test. For COVID, even if you don't get immediate results, if you have a positive result of some sort and the patient is at high risk, you can have therapy. Other than remdesivir, therapeutics for COVID-19 are not FDA approved. They're only available under emergency use authorization. So you're really not supposed to be using them off-label. And part of the use criteria is a positive test. So in order to give somebody therapeutics, you're supposed to have a positive test of some sort. Other place a lot of people get tests, in the emergency department. And this often requires a snap decision on the part of the provider. You see a person, clinical judgment. Are they likely to go home, or are they likely to stay in my big shiny building and be admitted? Okay. If they're likely to go home, it's fair to treat them as an outpatient clinic, with the caveat that a lot of emergency departments might be able to get fourplex results while the patient is still sitting there and waiting, so you can give them that PCR result before they leave. If you think they're likely to be admitted, and you can tell this by just they look sick, or hey, we had to give them supplemental oxygen, that kind of thing, it might be better to do an expanded respiratory panel a lot of the time. If you have somebody who comes in who looks sick, who says, yeah, everybody in my house has been diagnosed with COVID and I finally got sick, you probably don't need the whole panel. But other than those exceptions, it might be better to do the whole thing. Why? Even if you can't treat some of the things on there, your person is in the big shiny building with a bunch of other vulnerable patients. While you may not have directed therapy against a lot of these, you do have to isolate. And for most isolation protocols, if they're followed, just having the negative RSV, flu, COVID should not be stopping your in-hospital isolation. And therefore, in order to stop isolation, you have to look for the other things too that would require isolation. So that is just a brief overview of testing. Just like in the outpatient setting, if somebody's in the emergency department being admitted or not, and you can give them a test, you can find out, hey, maybe they don't need all of these antibacterials, and that'll decrease your risk of complications and the cost of your stay. Just a brief overview. I will now turn it over to the little folk, pediatrics. Thank you.
Hi, good morning, everybody. I'm so thankful to be addressing this Common Spirit family. Thank you for all the work you do, and thank you for being here. So I hope to leave you with some pearls, and even though I do have a lens of a pediatrician, I think many of the considerations apply to adults as well. So I'm going to share my screen. So as a primary care physician, this is not a new problem, right? We see respiratory infections all the time, and it is a very common problem with a huge burden. And we're always talking about preventative strategies to prevent spread, but also just the infection and all the subsequent sequelae and conditions. But as Dr. Greenswag said, you know, how do we approach it in the context of COVID-19? So today, I'm focusing on just a diagnosis. You know, as mentioned by Dr. Quimby, you know, a few viruses I'll be talking about, including RSV. He's already done a marvelous job going over the tests that are available and all the considerations. And I'll be going over an algorithm that we hope to leave you with for reference and use. It's there for your consideration. And then we'll also be talking about other considerations, including vaccines. So this is a big problem. As of August 4th, over 14 million child COVID cases were reported, and that's like 18% of the total cases in the US. And we do have about, you know, over 72 million children in the US. And one thing to point out is they report this data weekly, and the last for that week was the 4th consecutive week of rising cases. So how do we approach that sick patient? Considerations that we should know about are: what is the level of community viral transmission? We need to know our patients and their health conditions, their known or presumed exposures. Consider the costs, you know, of the things that we're doing, potential risks of you know, and that includes, you know, risk of exposure to other susceptible individuals. Are they in a school setting? You know, those kinds of things that we need to consider. There's a lot of things that factor into why we test or we don't test. And let's face it, it's traumatic. I think the biggest barrier to testing is, you know, this picture. It says it all. So this is an algorithm, a good approach to consider. So this is for testing for the symptomatic ambulatory patient, and this is applies to both pediatric and adult. So when you're seeing that patient, you're thinking about that patient, either the one that I just showed or yours in front of you. You know, we want to know was there a known exposure, and or what is the level of community transmission. And so if we know there was a known exposure or high level of transmission, and that's, you know, reported now daily, but you know, so you can know what's going on in your community, but you know, then you would test because you would recommend testing, and of course some patients are going to say no as well, but we could talk a little bit more about that. And then you would start the appropriate treatment. And you know, for young children, RSV is definitely a player. And I know our experience here in Phoenix in the past year is that all the pathogens have seemed to not be, you know, that like we saw the peak of flu here in our office like in May. So nothing is the same right now. But so, you know, so just consider these things. But we're talking about the fall and the winter as well, when we do expect to see a lot more flu and rising cases of COVID. Maybe not, but so If the answer to this question is, no, there's no known exposure and there's a low transmission as well, then, you still have a sick patient in front of you. And so then you're like thinking about risk factors, for severe disease. And so if there's like risk factors, then you might consider testing as well. So if the answer to that is no, then you're looking at the severity of the symptoms. And so if they're presenting with mild symptoms, you're going to just recommend observation. But, there's a caveat too, if they're needing the test because they're going back to school, and we definitely want to promote going back to school and the community, we want to support that, then you would do that. You would test. But otherwise, it's just supportive care, and then come back if your symptoms aren't resolving. If they've, done some testing, which a lot of families have, and I know I see a lot of these patients on like telehealth, and so I'm not even having the option of testing, but sometimes they've already tested them and they're negative and they want to know what to do, or they want a note from me to go back to school. But this is where, knowing the kind of tests that they did and whether they need to do serial testing and all those recommendations. And now I did have this bolded here in yellow and I forgot to say it, but while all this is going on, and as a primary thing, we need to emphasize, that while we're deciding one thing or the other, if they're symptomatic, they need to be, using their mask and isolating appropriately to prevent the spread. Now, if the symptoms are moderate or severe, then you would test and then decide treatment. And we know, that in the past, as Dr. Quimby pointed out, if we were thinking it was the flu, we don't even need a positive test. We can go ahead and start treatment for select populations based on recommendations. So, there are in-office tests that are rapid for RSV and for influenza and for, I don't have the 4-plex in the office, but I do have some quicker tests, and it's not necessary to do it in your office, because you can also refer them or recommend them. But I think and again, just recommending they supportive care and return to you. So if their symptoms are severe and they have an initial negative test, an antigen test for COVID, then you would recommend PCR testing. I want to segue to vaccines. There's been actually, at this point, as I talk to my colleagues, there's reluctance on the part of both the parents and also my colleagues. Not all of them, but, there's just like, what do I do? In vaccinating kids now, because, we're hearing that the vaccines are not as effective with the new variants. But there is evidence, I just saw some recent evidence that the vaccines are still protective from more severe disease and hospitalizations and even death. So the AAP still recommends, and the CDC, vaccinating. We've heard that, boosters are on the horizon. So some families, will come to you and say, should I wait? And so it's not clear exactly when that will happen, although we've been told they've been already testing, but I don't know, like for children, when that will happen. The vaccines, you know, there's now several vaccines available, and this is just a timeline, and I think many of you are well aware, so it's here for your reference. The most recent approval came in June for children aged 6 months to 4 years. And it's amazing, but we still are lagging in the number of children that are getting vaccines. And part of it is this reluctance. Part of it is many have already experienced symptoms or the disease, and they think it's over. And it was mild, and so they're scared. But there's still benefits. So you can see here for children under 5, we're as of August 3rd, 5% of 6 months old that have had at least 1 dose of vaccine. And for children 5 to 11, 37% of 5 to 11-year-olds have gotten at least 1 dose, and only 30% have gotten the 2-dose series. And for children 12 to 17, 69% have gotten at least 1 dose, and 59 have completed the 2-dose series. And some, I'm seeing a lot of kids that have had the booster as well in this age group. I don't have that data. So why vaccinate children for COVID? Well, yes, they can get infected, and they can get sick, and they can spread the virus to other people. So we're trying to contain the spread so that people that are more at risk, and including children that appear healthy, you know, during this whole pandemic, you know, some children with no underlying health conditions have gotten very sick. So the other thing is, just a week ago, we had a report, and I included the reference there, that compared with children that are age 0 to 17 years old without previous COVID-19, those that had COVID-19 had higher rates of acute pulmonary embolism, myocarditis, cardiomyopathy, venous thrombotic event, acute and unspecified renal failure, and type 2 diabetes. And all of these are rare or uncommon, but they are being seen with increased frequency. So that's something to take a note of. And to me, it appears that this is just the whole population that they compared, and not children that presented with severe illness. So it looks like, you know, that's something that we need to protect against. And, you know, let's not forget overall improved health imperative. So, you know, we learned these past couple of years that health behaviors, including, you know, vaccination, social distancing, quarantining, they're all important to manage the pandemic, but we had more complications, more deaths, more morbidity in people that were in poor health state. And so it really is important to, you know, prevent those conditions and continue to think about that in the overall picture. And, you know, healthy living all the time includes awareness and, you know, avoiding close contact with people who might be sick, you know, staying home and preventing spread when you are sick, you know, and that includes, you know, this is like for always, right? Covering your mouth and nose, cleaning your hands, avoiding touching your eyes or nose, and just practicing good health habits. And with that, thank you, and I'll turn it over.
Thank you both, Dr. Quimby
stop.
and Dr. Pararodi. And let's move to our panelists. Here they all are. Good morning. And I think the key is what advice can we offer providers in the context of flu and COVID? And I think we've kind of gone a fair way down that journey this morning. I think we are going to ask Karen to talk a little bit about adult vaccination for flu and COVID, and of course, flu vaccine notwithstanding, and COVID. Thoughts about that, Karen?
Yeah, thank you. It's my second time talking grand rounds about vaccines, and definitely consider myself one of the vaccine evangelists, talking a lot in the community, done a lot of community vaccine events. And I think in early COVID, we were so focused on just getting vaccines out in the community. We were running in the country about 67% vaccination rate, but the key to right now is having people get their boosters. And so when you look at, we're 67% across the country receiving their first series, that number drops to 48% of folks that have actually received their first booster. And I think that's the population, especially in our primary care group, that we can address and get our boosters out. We know in our over 50 crowd, you're now allowed to get 2 boosters 6 months apart. When we look at people that are eligible for their second booster, that number drops to about 30-some-odd% across the country. And I know in primary care world, you're seeing patients calling all the time that are symptomatic, they have COVID, and we can tell you on the inpatient side, we're not seeing those sick patients come in, and it is because of the vaccination programs. When you look at the vaccinated versus the unvaccinated, Dr. Para kind of alluded to this, but you're 9 times more likely to die of COVID if you are unvaccinated versus someone that is vaccinated and boosted. And so the booster part is still the key to keeping people out of our hospitals and keeping people from advanced disease. And we just did a bad job at messaging early COVID what the goal of vaccination was. When I talk to people now that maybe got their first series but don't want to continue on and get the boosters, every time I talk to someone about this, there's the same answers. Well, it doesn't really protect you from getting COVID anymore, so why should I care? I'm still going to get COVID. Why should I go get another shot? And that answer goes back to that you're way less likely to end up in the hospital, and you're way less likely to die of COVID-19 if you were vaccinated and boosted. And that's the data we can keep hounding through our patients and kind of using that data point. And also, as we move into cold and flu season, we want to get influenza vaccine, we want to get COVID-19 vaccine, but also like pneumonia, pneumovax vaccines are also one of those vaccine preventable respiratory illnesses that we see a lot of in the hospital. And that's something else that we can kind of work on in primary care, just to kind of increase the awareness and get that vaccine out in the community as well. But any other questions on the COVID?
Yeah, I think a couple of folks have talked about it, and it's a different variant and not that effective against that particular variant. So why do it? And I think you've answered that, and we all answered that way. But I think that is the key in terms of downside morbidity, mortalities, and so forth. A huge change for those folks who have been vaccinated. Dr. Quimby, were you going to say something there? No, you weren't. Okay.
No, other than I am not in the over 50 crowd. I do have a recent bout of COVID, and one problem is my vaccines are a lot older than everybody else's vaccines because I was in the initial Moderna study trial. But despite my otherwise health risk factors, I didn't end up anywhere other than at home.
Okay, we have Ankita, were you going to say something or no? Oh, you may be on mute or double mute.
Is that better?
Yeah, so much.
Okay, great. I guess I was going to ask Karen, especially when it comes to sort of grabbing them at that opportunity time when they're in our office, and then the question inevitably comes up, oh, I don't know if I want to get my flu shot the same time the COVID booster. I have an appointment for tomorrow. Should I not? What are your thoughts? Like, what's the recommendation? And especially when we're trying to get multiple vaccines into people at once.
During our first round of COVID vaccines, we were recommending you wait 2 weeks in between all vaccines. because we're sure the efficacy, and that changed somewhere in 2021 that we can now give multiple vaccines in one appointment. So now we can, I would recommend giving all of them at once if we can. Knowing that you might not feel so great the next day. Sometimes I will recommend my patients maybe hold off on getting Shingrix with their booster if they feel really bad after their first booster, because Shingrix can make you feel a little bit under the weather for a few days, but otherwise I would recommend getting all the vaccines at once. Get them while you have them, use the opportunities you have. And I also challenge for anybody here who's not in primary care, this is everybody's problem. Me as an ID clinician, of course I look at, our care gaps and look at vaccines, but whether you're a surgeon who's prepping that patient to come in for their elective surgery, we don't want to delay. We know COVID positivity is going to delay that surgery. It's another talking point with patients. It really affects all of us in different ways. So whatever your subspecialty is, and you have that patient in your presence, use that opportunity to, check and make sure and say, hey, have you gotten your primary care appointment next week? You haven't gotten your booster, or hey, I noticed you haven't gotten your COVID booster. I'm sending in your prescription. Hey, while you're at your pharmacy, why don't you ask if you get your COVID booster? And I've been doing that a lot with patients, saying, hey, you're due for your booster. When you pick up your script, why don't you just get it while you're picking up your prescriptions, and trying to just motivate them and make it easy and make it less of an inconvenience for them. Something I've been doing a lot lately.
Yeah, and I think our strong recommendation for primary care practices across Common Spirit is that people get them both, flu and COVID. Now it could be, late September, October, maybe there'll be a combination product, but until that time, I think we are really focused for all of our clinics to be sure that they're vaccinating for both flu and COVID. And last year it was, well, should we sort of, and as Karen said, the recommendations changed where there didn't need to be a 2-week wait. And even last year we advocated that both of them be at the same time. There's a couple of questions. The first one is, what are your thoughts regarding the combination COVID flu point of care tests that there's discussions in California about potential use? And just one thing before the panel answers that, when we look back a year, I think people sort of band-aided together their testing solution, community by community. In some places it was antigen testing, in some places it was the Abbott ID Now, which is molecular testing, sort of like PCR testing and so forth. So there, and then the office flu tests that have been available for a number of years. But things are changing. That the quadruplex test came out last year, and some offices have the capability to do that. I think it's Cepheid has a product like that that's for office use. But thoughts today about COVID and flu point of care tests?
I'll start. In general, if you're making treatment decisions, a point of care test is, if it's a valid test, it's going to be a lot better than getting results in 24 to 36 hours. One, because if you're treating a virus, in general, the earlier you treat, the better your antiviral has an effect. But you just need to pay attention to what tests you're doing, because if you're doing currently available antigen testing for COVID, a negative does not exclude the disease. Given the prevalence,
right,
a single negative test on an antigen, you could still very easily have COVID. So if you give somebody a negative antigen test, you're just going to have appropriate counseling and say, okay, in order to exclude this, you need serial tests, and stay home still, please.
Yeah, I think we talked a little bit about this yesterday, and we've become highly reliant on antigen testing for good reason. But we talked about but you need to retest if you're negative, particularly in the context of if you're symptomatic, A, and B, if you're in a high transmission area, which is almost everyone. But the comment was made, look, I just need a negative test so I can send my kids back to school, or I can go back to work, or whatever it may be. And so I do think there's this dynamic tension around the use of antigen tests, and I think they're great. But even though they're much more specific if they're positive, there are false positives out there as well. So the other question is, will masking guidelines within Common Spirit Health be changing? And that's sort of the $5 million question or the $100,000 question. And I think until the CDC guidelines change for healthcare facilities, it's unlikely that Common Spirit will change. And at least today, as far as I'm aware, that for healthcare facilities and for folks in clinics and hospitals, masking is still required. And I have not heard that being taken off the table yet. And Dr. Quimby at Creighton, any thoughts there in the Pacific Northwest?
No, this is in regards to
Karen, yeah, but
the
for both.
CDC guidance yesterday, because they did update their guidance, but it was not for healthcare facilities. That was strictly in the outpatient world. And I do recommend if you want to, for people to review that, because they did kind of, you alluded to the test out when you're testing to come out of isolation. They removed a lot of those kind of guidelines. It's supposed to be a little bit clearer. There's still a lot of if-then statements about, which I don't think it's super as clear as they wanted it to be. But I definitely would recommend reading that guidance because it did change quite a bit.
Right.
And when you're looking at the guidance and stuff, there's a difference between what's actually in the guidance and what's put out there about the guidance. For example, the most recent update before this one, it was, oh yeah, 5 days, you're good. That specifically said not healthcare facilities, but everybody in the public and even some healthcare workers kind of tried to gloss over that bit. Yeah. We do have big shiny buildings full of vulnerable people.
So no change, at least to start. I want to be sensitive to the time. And just before we close, I wonder if we could bring up the algorithm again, just for a second, either John or Ankita, or who has the quickest access to it. But, things have changed a lot in a year. And I think COVID has changed as well. And while, a year, 2 years ago, if you got COVID, it was like getting the plague, the outcome was unknown. And it really was a very difficult problem. And I think what you're seeing in this algorithm, and Dr. Sagar gets the credit for simplifying this, is if people are symptomatic, there is some time to, particularly with kids, how many kids come in with a runny nose, and then the next day it's gone, and allergies and so forth. And so it's kind of leaning in or leaning out in terms of testing and such factors as risk factors for severe disease makes you lean in, duration of symptoms makes you lean in, severity of symptoms makes you lean in. And at least on my screen, I can't see the whole thing. There we go. So there is this period of you can wait 24 to 48 hours. Hopefully, you have people calling and saying, "What should I do?" And you can ask people to wait, and then if it's unresolved, consider both COVID-19 and Influenza A/B testing. If folks are not getting better, but one thing we talked about a couple of times this week is it's okay to say wait, but in the meantime, you need to have folks isolating and wearing a mask, because at the end of the day, you can wait, and then 2 days later it's positive, and your child or your spouse or somebody has exposed the entire family to COVID. And so, and we hear about that. So I do think that's something to keep in mind, that it's both. You can sort of lean out as opposed to leaning in, but that isolation and masking is key. Ankita, any thoughts from you about that?
I think you covered most of it. The only other thing that I would like to think about, and I think Dr. Parvati mentioned this in her talk, again, when we're thinking about children under the age of 5, when should we test for RSV? I think that's an important consideration. But also to think about children who might be at higher risk for moderate to severe disease when it comes to RSV and exposure. Dr. Parvati, I don't know if you wanted to speak to that a little bit.
Yeah.
Sort of the conversation we had earlier.
Yeah. So for RSV, I think about it, especially, the younger children. And, the younger they are, like under 1, is probably the highest risk with bronchiolitis. And really, RSV, again, I look at the severity of the illness when deciding if I'm going to test, because like if I see a 1-month-old with congestion, I would want to know if that's RSV, because in a day later, they could be severe. So what we know about bronchiolitis is that about 1/3 of RSV goes into the lower respiratory tract, but then the other 2/3 really stay just like an upper respiratory infection. And so you're not really going to do anything different in those kids than you would for a normal cold. And the treatment for RSV is just supportive, and so in the context of what I would do and why it would matter to know if it's RSV, I'm really worried about that little baby or somebody that has an underlying condition like asthma or cystic fibrosis, or something else that is going to complicate matters. And when you hear bronchiolitis, it's not hard. It's just that window of time when you want to counsel some families about what's going to happen in the next few days. What do I need to be looking out for? And even when I see just an upper respiratory infection, I'm having that discussion with families. Some of them opt not to test because they think they can watch for it. Some families really want to know. But so those are the considerations. I don't know if that helps. It's always like a balance between the patient in front of you and everything else that's going on.
All right, I think that's good, and I think it's also if there are other people, maybe the child doesn't have the risk factor, but maybe their brother or sister does.
Exactly.
Right, and so I think that's another thing. Just the last comment. I think there's been a lot of data over the last several months about the efficacy of antigen testing in the face of new variants, and so and I think there's been studies by brand of test. So, well, this one seems to work in Omicron, this one doesn't work on BA.5, but it works on BA.2, and so on and so forth. So they're a little less trustworthy, which I think speaks to the whole comment about retesting or even alternative, go to the store and get a different one. But I just think they're not as reliable as the virus has continued to change. And David, any comments about that before we close?
No, there was a recent meta-analysis that was talked about on, I believe, one of these some odd weeks ago, and it shows sensitivity of, when you looked at this one, of high 70s%. But there are other individual studies that it's in the 60s. So it's just a negative. You just have to know, even like the old flu tests where we're happy with 50 to 70% sensitivity, a negative does not exclude the infection.
Right. So it boils down to old-fashioned clinical judgment. Right. There you go. Okay. I want to thank our panelists and guests. Great conversation, and really this is part of us gearing up for flu season in the context of COVID, which means flu vaccines, COVID vaccines, testing that we talked about. The algorithm will come out. We keep adding little tweaks to it to be sure that people understand it clearly, and anything that we can do to help clinics prepare, be ready, and certainly to get their flu vaccine program started is key. So thank you, everyone. It's been a great morning, and I hope people have a great weekend and have a safe weekend. So thank you very much for joining us.